Okay, so first things first, we need to answer this question. What asks no questions, but has to be answered? What asks no questions, but has to be answered? What's that? A telephone, that's pretty good. I like that. It's a doorbell, but I'd go with telephone as well. Nice enough. More of a riddle, not really a joke, huh? Why did the football coach go to the bank? To get his quarterback. And how about this one? How do you have a successful solar system party? Because you know you want one, so. Huh? Invite the stars. Ooh, that's good. You're very good at this today. You plan it. All right. Like, all right, it wasn't going to be on my review, but now the jokes are on my review. Okay. So this is the last slide that we covered the last time that we were together. And so I'm backing up just a tad to remind us of some of the symptoms that we have and experience with type 2 diabetes mellitus. So we've got overweight, and in a lot of cases obesity, dyslipidemia. So this is a word that refers to the abnormal levels of lipid and that are in the bloodstream. Hyperinsulinemia, so too much insulin because you're not responding to it. Hypertension. Hypertension meaning that the particulates or the solutes within the blood are high, so that encourages fluid to stay within the bloodstream, and because of osmosis, water is going to follow where the solutes are, go to where the solutes are. That raises pressure within the bloodstream, and that hypertension can cause endothelial damage to the endothelial lining. Fatigue, because you're not getting enough energy supply. And these recurrent infections, and this is kind of where I wanted to pick up on. And so these are diabetic foot ulcers that don't heal. As a result of these infections and the vascular damage that takes place, we see this issue known as parathesis, which is that pinprick feeling, and that's the early sign that a nerve is starting to die. So what's leading to all of this is really where we need to start, because this is where we said we ended. These complications that come from diabetes mellitus are a result of what we call AGEs, advanced glycosylated end products. Basically what this is sugar coating. Sugar coating things that are within the bloodstream, because there's high levels of glucose floating in the blood. And glucose likes to bind to things and glycosylate products. It's going to glycosylate proteins. It'll even glycosylate fat. It sugar coats the protein. Okay? So what that ends up doing is this coating, you have a collagen protein, you get cross-linking that takes place as a result of this, and then you get fats that stick to it as a result. You'll get plasma proteins that are floating through the blood. And the advanced glycosylated end products, the AGEs, will bind to those plasma proteins. And they will cause those plasma proteins to even become sticky. And they can actually start adhering to the endothelial wall, especially where the damage was, because these patients have hypertension, and hypertension causes damage to the endothelial lining. And that exposes a basement membrane of the blood vessel, and now you have sticky, sugary proteins that get lodged there. And now you have a lesion inside the lumen. So the reason I wanted to go over this is this sets up next week's lecture. Does that make sense? So I didn't want to skip this, because this cardiovascular disease that we see in type 2 unmanaged diabetic mellitus patients is very, very classic and representative of what we see in our average, overweight, beyond middle-aged, non-exercising, non-healthy, non-watching their diet American. And they have broad-based cardiovascular disease. So in unmanaged diabetes mellitus, it's probably a good idea to add that little language in there, unmanaged. just because a patient has diabetes doesn't mean they're going to get all these things. You guys with me? This is when they don't take care of this underlying disease condition, these are the side effects that result. So it'd be the same thing as if you have a shellfish allergy, right? You could die, right? You wake up every day and go, I might die today. Yeah, I might run into a shellfish. So you're going to be cautious about it, right? You're going to ask when you go to a restaurant, we have a peanut allergy. You're going to say, hey, now a lot of the restaurants say, please let us know if you have a food allergy before they make the food. So you're going to be prepared. So it's not like a patient that has diabetes, whether it's type 1 or type 2, is going to have these symptoms. It's only if they're not paying attention. Okay? So one of the other additional results is that this glucose within the bloodstream is going to activate protein kinase C. This is a cascade event that's going to start stimulating VEGF and other types of angiogenic molecules. And so what that does is it floats within the bloodstream vascular endothelial growth factor, and it hits tissues that don't have large amounts of blood vessels. Okay? And it'll cause excessive blood vessel formation within those tissue beds that don't normally have that much blood vessels. And that's another side effect. And this manifests itself within the retina. And now on a retinal scan, you'll see with diabetic retinopathy, you'll see abnormal vascularization taking place. Again, as a result of activating protein kinase C, upregulating VEGF within the bloodstream, and allowing its effects to become systemic. That means all over the body in areas that aren't used to seeing VEGF. Now, as we continue down this pathway, we need to look at this chain of events, or this reaction known as the polyol pathway. So here you can appreciate the glucose molecule, and through a reaction using a reductase, we get into a sorbitol intermediate, and through another reaction using a dehydrogenase, we get down to fructose. So essentially you go from high glucose sugar levels in the bloodstream to high fructose sugar levels in the bloodstream. So glucose effects on the last slide are not the only thing that we have to worry about. If the glucose sticks around in the blood, it essentially will turn into fructose as a byproduct. And now, if you get fructose in the bloodstream, this gets stuck there, and it increases the osmolarity of the blood. And now water is going to follow that fructose, and you increase water accumulation, causing additional cell injury to specifically the endothelium, on the endothelial wall. Okay? So this polyol pathway takes glucose down to fructose. Now, if we focus in on the different systems that we've talked about, there's three main ones. Vascular disease that we've just characterized as a result of damage to the endothelium. And we'll see that damage to the endothelium play out next week when we finish out our entire semester with cardiovascular disease. And then we talked about diabetic neuropathy. Right? Neuropathy is the dying of the nerves, the neurons. And that happens because the nerves need a blood supply. If the blood supply is being compromised, then the nerve is going to starve, and that's that parathesis, which is that early warning sign that the nerve's dying. And then diabetic nephropathy. So the diabetic nephropathy is a disease that targets the capillaries within the kidney glomeruli. Right? So you get angiopathies or diseases of the kidney glomerulus, just like you see in the endothelium everywhere else in the vasculature, and then that starts causing damage to the endothelium of the kidney, and now you get compromised renal function, which you learned about last week. Okay? And so in its end stage, with type 2 unmanaged diabetes, there could be renal problems as a side effect. So it's not a good disease to let get out of control. You guys catching on to that? It's sort of a summary statement. So if we look at the vasculature, There's microvascular disease and then there's macro. Micro meaning the small vessels. And so with the advanced glycosylated end products, you get a thickening of the basement membrane. So this histology is showing here is a normal basement membrane. Here's another normal basement membrane. See how thin it is? Look how thick the pink is on these guys. These are thickened basement membranes. And that's because of the ages that are actually binding to the basement membrane and causing a thickening of that particular layer. And that's going to prevent oxygen diffusion, right? If you have a thicker basement membrane, oxygen is not going to diffuse as readily. And so perfusion levels, even if the bloodstream is still open, are going to be compromised as a result of this thickening. This microvascular disease, here's the whole list of things that it can cause. Renal failure, nerve problems, neuropathies, retinopathies in the eye, blindness in its extreme. And then the macrovascular disease, we're going to touch on more next week. And this is the vessels that perfuse the heart itself. Those also are having damage taking place. And so a type 2 diabetic that's unmanaged has this global microvascular disease and macrovascular disease. They're going to start getting organs like kidneys, the distal extremities, the eye, even the heart having problems because all of those organs are perfused by the bloodstream. This LDL, low-density lipoprotein, will start getting stuck or accumulated within the vessels of the coronary system. And we'll talk about that atherosclerotic disease that takes place next week. Type 2 diabetics are not the only ones that get that if it's unmanaged. Patients who have too many Big Macs and not enough walking also get it too. And so the heart itself can go to a condition of infarction, myocardial infarction, which is a word for heart attack, or if it's the vessels of the brain, now the patient's susceptible to strokes. So if we look at diabetic neuropathy, the nerve damage that takes place, it's going to want to target the lower extremities first, because you get this polyol pathway that causes this endothelial damage. That causes those smaller vessels that go down to the distal extremities to be compromised. Now, blood flow doesn't go to that region, and the nerve itself doesn't get the appropriate amount of perfusion. And so as the blood flow to the lower extremity is compromised, the first thing before it goes gangrenous, if you have an infection, is you get this nerve damage, and you feel what we call limb claudication, peripheral limb claudication. So this is, claudication is a clinical term that means pain while you're walking. And so as they're walking, it hurts. And while they're sitting down, it's like numb and tingling. And that never goes away, but it kind of turns into pain. And you've probably seen some of the commercials for a drug, a recent drug, known as Lyrica. Have you guys heard of Lyrica? Lyrica. It's not like this lecture sponsored by Lyrica or anything, but it's interesting to see these new drugs when they come on the market. Lyrica numbs those peripheral nerves, so you lose that pinprick feeling. It helps mask the symptoms. It doesn't do anything on revascularizing. It helps to have that pain subside specifically to those nerves that are dying off. Okay? Now, if this goes really unchecked and continues, then you get to this stage of these wounds, and these are classic diabetic foot ulcers. Okay? And the problem that's taking place, we got a high glucose content. The vasculature now, is compromised. You know how it's compromised, because that glucose will cause ages to take place. Advanced glycosylated end products, they cause damage to the endothelium. The glucose will also convert to fructose and cause an increase in osmolarity that also causes damage to the endothelial wall. And the increased glucose on a red blood cell also prevents oxygen release. It kind of keeps oxygen on the red blood cell rather than letting it go. All of this leads to poor perfusion to the distal extremities and these injuries that we have to end up treating. This just happens to be kind of a main area of my research, which is trying to heal wounds, specifically even diabetic wounds. Now, we've got some treatments that take place, so it's not all bad news. You're like, okay, that's if it's not treated, so how do we treat? Well, if it's type 1, it's very common that it's an injection of insulin. Okay? And the patient's going to be monitoring their insulin levels throughout the day, and as long as they don't rise above a certain set point, and it's usually patient-specific, but it's usually pretty physiologically homeostatic. And as long as it doesn't drop below a certain level, then they would have to eat something or have some sugar in their bloodstream, then they're going to be operating in a homeostatic norm. Now, why do you suspect that we haven't had as much success? Now, there's been some success. There's been some clinical trials, but it's not as widely distributed as a pill. Insulin as a pill. Yeah, so you've got enzymatic activity in the mouth that can denature the insulin and enzymatically degrade it, so it's no longer effective. Okay. Absorption time is pretty slow orally. Okay. It would take you 30 minutes to an hour before your insulin levels in your bloodstream were representative of what you needed. You'd have to have a high amount of insulin in a pill in order to translate to physiologically relevant blood insulin levels to do something. You guys with me? So it's just not the most effective way. That's why we haven't done it broadly. It's been investigated, and there's been some success, but these are some of the hurdles that you all are going to have to overcome if you go into this type of research. Now with type 2, there are various drugs that can be used. Some can be orally administered, and some can be injectable. And it's not uncommon to be treating a type 2 diabetic with insulin. And this always confuses students because they say, well, I thought type 2 was unresponsive to insulin, or maybe they just didn't make quite enough of it and became or desensitized. Why would you give them insulin? They already have a lot of insulin. Well, you can give synthetic versions, or you can give alternate forms that are more potent. And then the patient is no longer responding well to their insulin, but they might respond well to a synthetically derived one. Okay, so there are some cases where patients who are type 2 diabetic will be also treating very similar to a type 1 diabetic. And they're monitoring their glucose levels, and they're injecting with insulin as prescribed to keep their glucose levels at sort of a homeostatic norm. The oral tends to be more effective, the pill, for the type 2 diabetic than type 1, because in a lot of times with the type 2, it's not that you don't make insulin, it's just you become less responsive. So if you took insulin on a daily basis as a pill format, then you could help use that to regulate your norms. Okay? So it's been more successful with type 2 than it has been with type 1. Diet modification is a big one. Even eating habits. Okay, so a lot of type 2 diabetics will tell them, watch the sugar levels, watch the carbohydrate levels. Instead of having 5 pounds at dinner of food, why don't you have a nice healthy breakfast. If you get a little hungry through the morning, then have a nice healthy snack like some nuts, or maybe some yogurt that's low in sugar. Okay, and then a healthy lunch, a snack, and then a modest dinner instead of this ginormous meal. Our problem with 3 meals a day is we go through fasting situations and then feasting situations. And what our body does is it takes our 3 peak times that we eat, and it tries to normalize it throughout the day. So there's a lot of nutritionists and folks that focus on diet and say, you really shouldn't be eating 3 meals a day. You should be eating small snacks throughout the day, all day long. It'll help keep your blood glucose levels like this, so your body doesn't have to do so much work. You're kind of doing it for itself. Okay? I'm not prescribing anything to you. I'm just saying this is where a lot of these theories are coming in, and there's some merit to it. If we have 3 big meals a day, there's giant fasting times in between. And then right after the meal, you go into food coma because you're like, oh my gosh, I can keep my eyes open. I can hear this guy for like 2 hours. Okay, I'm just going to skip lunch next week. Okay, so it's diet modifications are huge, and this is patient compliance is hard because we're built into a society where we eat, 3 times a day, and they're big meals, right? The one that I really want to drive home is exercise. And when you combine diet and exercise for these patients, it's super effective. And here's one of the reasons that exercise is so effective for diabetic patients. Okay? And this actually is even beneficial for both type 1 and type 2. Okay? The diet modification and the exercise. This isn't just only type 2, but it seems to be that the type 2s are the ones that have more challenges with lifestyle. Because type 2 typically is adult onset. It's very often associated with overweight and obesity. And so that usually means that there hasn't been a prescribed regimen of exercise throughout their life, and they haven't been really paying that close attention to their calorie intake or their food or their diet. Okay, whereas the type 1 diabetic usually has a slightly different profile. Okay, they are wrestling with the insulin not being there, but they may be extremely lean and fit. And so it's not really an issue of being desensitized to the insulin over the years. It's just that your body now has attacked the pancreas and it doesn't make it. But both of these diet modifications or diet adjustments, maybe a better word, and exercise are extremely beneficial for both patient populations. Now, if we look here at what's going on, this is a GLUT4 transport protein. And what GLUT4 does is it moves glucose independent, really, of insulin. It's an insulin-independent pathway to move glucose. And what exercise is going to do is it's going to increase the number of GLUT4 transporters that you insert into the membrane. So on this slide over here, you can see this is our insulin pathway, and this is our GLUT4 pathway. And so using a GLUT4 pathway, really independent of insulin, the insulin can signal GLUT4, and that's what this is showing. Insulin can signal GLUT4 to upregulate, but exercise also does that. So exercise will do what insulin is supposed to do if insulin's not doing the job. So if we prescribe diet adjustments, lifestyle adjustments, and exercise to our patients, we're naturally going to start increasing GLUT4 insertion into the membranes of the cells. And you're going to get glucose coming into the cell sort of using a side door approach that is really independent of the insulin signaling pathway. Okay, and that's why it's so valuable. So when you read these pamphlets and you're like, hey, diet and exercise, there's actually science behind it. Okay, and that's why I want to take the time to explain it to you, because you guys are going to be the ones who can go out into your communities and affect your own patients. And if you can explain to them, they don't say that because it's just popular. They say it because there's actually data that supports it. Okay? So that wraps up that little segment that we didn't have a chance to finish. And, again, my philosophy that I've been doing all semester is, we may not get to it right away, but we will get to it. And I would rather do it well versus just rapid fire through the slides. Questions?